Hi, my name is Michael Carsey. I'd like to talk to you about our project for Bench to Bedside, termed the VizPort. This project was done in conjunction with Brandon Pope, Brandon Sherrod, and Brian Farns. We sought to find a better way for the treatment of hydrocephalus. Hydrocephalus is a condition resulting in excess production of cerebral spinal fluid or inadequate absorption of the cerebral spinal fluid, and it's typically treated with a ventriculoperitoneal shunt, shown here on the right side. There are about 30 to 50,000 of these cases performed annually in the U.S. and even more performed globally. Many problems exist with the shunts currently. However, the ones we sought to fix were several of the infection problems, accounting for 5 to 10% of shunts, as well as bowel and vascular injury, which account for 1% of shunts, and currently a technique used for placement of these shunts distally, which surgeons currently don't like. Shunts are placed by putting a catheter proximally into the ventricle shown here, tunneling the catheter underneath the skin, and placing the distal component into the peritoneal cavity where fluid can be absorbed. Treatment of hydrocephalus with shunts continues to expand at a significant rate in the U.S. Approximately $35,000 is the cost per case in the U.S., and this continued to expand in the years thereafter. For the shunt market, this is approximately $2 to $8 billion market if you include the shunts and all the complications and diseases associated with shunts, and a market of approximately $1 to $2 billion for hydrocephalus itself. About $300 to $3,000 per case average out if you account for all the takebacks and complications that result from shunts. And the CAGR for shunts is about 2.3% in the US and even higher globally. As shown on the figure on the right side, for our estimates between the low and high estimates of the numbers of shunts in the US, they approximate 30 to 50,000 cases and continue to expand as the population grows over time. There are three specific methods that are used for placement of the distal shunt catheters. The first is the indirect trocar method. Basically, this is a blind puncture with a disposable or reusable trocar into the peritoneal cavity. It's the most commonly used technique. This device costs about $100 to $300 per unit, but it's fraught with complications such as difficulty in identifying the proper cavity, resulting in misplacement of the distal peritoneal catheter, as well as injury to any bowels, vascular structures, or other organs within the abdomen. The direct cut-down method is a method where a larger incision is simply used to visualize the peritoneal cavity and place the distal catheter. This results in a larger incision causing more discomfort, pain, and potential complications for patients. It is thus the least commonly used method that currently is used for placement of distal shunts. And then direct laparoscopic method is one that involves the use of general surgery, and these laparoscopic ports, anywhere from 1 to 3 of these ports are used per case. It's less common simply because of the limited resources in acquiring general surgery and having laparoscopic equipment available. These ports cost between $200 to $300, plus you have to add the general surgery fees, which add about $600 to $800 per case, and these are a lesser common method of placing a distal catheter. We felt that there was a need to improve placement of the distal shunt catheter. We wanted a method that had improved accuracy and safety, one that reduced revision and complication rates, something that improved visualization of the placement site, and something that was easy and useful for surgeons. All of these needs were analyzed through multiple focus group and survey studies that we have done. Our solution was a multi-part optical trocar that was disposable. Essentially, this solution involves a 3-part system where you can place a laparoscopic camera into the initial end, be able to visualize placement of the trocar into the peritoneal cavity, be able to insufflate the peritoneal cavity with CO2 gas to be able to better visualize placement of the shunt, remove the camera port as well as the side port, and be able to place a catheter through the side port directly into the peritoneum. This is our model prototype after multiple iterations, both assembled and disassembled. This is how the device is used. Essentially an entry site, 3 centimeters inferior to the subcostal point, hence known as Palmer's point, is one of the potential areas that this trocar can be placed. One can place a Hassan needle or Veress needle to help insufflate the abdomen, or it can go directly with the device under direct visualization. The peritoneal tissue is lifted up. The catheter trocar system is essentially placed into the peritoneal cavity. This can be used with the endoscope in position or blindly and with follow-up endoscopic visualization of the peritoneal cavity. Insufflation of the peritoneum can be performed. The camera obturator is removed. One can then place the camera into the camera cannula here. The catheter obturator can be removed before final placement of the catheter through the side. We performed an animal testing of our early prototype. Here is the prototype shown here in this assembled and disassembled configuration. We used the porcelain or pig model. We made an incision in the peritoneal cavity, approximately an area that we may find a human. We placed our device. This is initially done both in a blunt manner as well as a visualized manner. Here you can see with the endoscopic camera in the assembled device passing through the peritoneal layers of the pig. And you can see as you get closer to the actual peritoneal cavity, it clears up. Here's with the abdomen insufflated. The camera is placed through the camera cannula. You can visualize the large bowel of the pig. You will be able to visualize the gallbladder and the liver. Gallbladder is here, and liver is underneath it, indicating that we can actively insufflate the abdomen and clearly visualize structures. We then place the catheter under this direct visualization shown here and could then visualize that it was in the proper placement and then removed our device. We also were able to detect faulty placement of the catheter. Basically here is the device where it's shown in a pre-peritoneal or incorrect position where we could directly visualize it and then halt the procedure and correct the surgical error. So the device showed that we could both identify the proper placement and then prevent us from inadequate placement. For our devices, there are several other patents that are similar within this space. As of current, we have a provisional patent that has been filed and submitted. This has been a disclosed device with the TVC. 2 other patents are shown here. There are multiple patents for companies that make laparoscopic trocars, namely Ethicon, Covidien, and Applied Medical. However, none of the patents by these major companies involve the principles that we are employing in our current device. Here are those similar products and similar companies. Common, as you remember, is that disposable trocar. That is currently the most common device used for shunt placement. Medtronic or Covidien, Applied Medical, Johnson & Johnson or Ethicon are the other companies that make laparoscopic ports. Here are their portfolios, and you'll see that there are no devices similar to what we are proposing here. We anticipate that this will be a Class 2 device. We have identified the specific regulatory pathway. We anticipate that a 510(k) pathway will be used with predicate devices. We've looked up and identified the similar predicate devices as well as the testing required and identified how they can be done in a benchtop setting. In terms of our business plan, we have currently formed a limited liability corporation called Cyber Surgical based out of Utah. These are the various team members with their various experiences. And this will be the primary team that initially takes the device from prototype through testing. But eventually we'll be teaming up with other partners as indicated to develop the device. In terms of the business plan, we anticipate these are the startup costs minus any salaries for additional individuals that would be needed to hire onto the project. The startup fundings we have are mainly through Bench to Bedside and I-Corps, for which we've been able to generate multiple prototypes. In terms of molding, packaging, tooling, they're all kind of shown here. All of our direct coats are shown in black as we discussed with various companies nationally to get the best quotes we could. Here are some of the filing fees for 510 clearance and biocompatibility testing. All the orange numbers are estimates that would be adjusted as the project gets further developed. In terms of the business plan, we anticipate the actual cost of goods sold would be about $297 per unit for the first 12 units in the first month of production, and this price should significantly go down as our economies of scale grow and we'll be able to manufacture the device um, more easily. And in terms of the return on investment projection, we identified that within the second quarter of sales, if we estimate it with approximately 5% market share at $100 a device, we could overcome the startup cost for this type of business and be able to turn a profit. This is again just for the cost result needed for development, regulation, clearance, as well as initial manufacturing. It does not include any of the salaries for personnel that would need to be hired on for such a project. We're excited to have become part of the bench to the bedside for this past year, and really excited in the developments of this prototype and the idea. I would like to thank the bench to the bedside team, as well as members from the TDC and CMI with their help on many of the aspects of this project. Thank you.